Welcome to the deep dive. Picture this. You're standing in the OR, scalpel poised, or maybe you're in the ICU, trying to read the subtle language of a patient's hemodynamics.
Mm-hmm.
Every flicker on the monitor, every breath, every single beat, it's all trying to tell you a story, right?
Absolutely.
How do we quickly, accurately interpret that really intricate dance to make those split-second, potentially life-saving calls? Because, let's be honest, in our world, those seconds can define outcomes.
Precisely. And that's really the heart of our mission today. We're taking a deep dive into the dynamic, ever-evolving world of vital sign monitoring.
Yeah.
And we're specifically zeroing in on that critical distinction between static and dynamic parameters.
Right.
Our goal for you, listening in, is really to cut through the immense volume of information out there, extract the most crucial, maybe game-changing insights from the latest research,
Yeah.
and basically shortcut you to being incredibly well-informed on this, well, pivotal aspect of patient management.
Absolutely, because ultimately moving beyond just those traditional snapshots, the single CVP reading, it can fundamentally revolutionize how we approach something as critical as fluid management
Totally.
and how we detect patient deterioration early, sometimes hours or even a full day before it becomes obvious,
That early detection is key.
and how we prevent complications that could otherwise have, well, devastating consequences. So how do these shifts translate into better outcomes for our patients? Let's try and break this down.
Okay.
For so long, we've largely relied on what we call static measures, haven't we?
Yeah, we have.
Think about central venous pressure, CVP. You'd get that single number, a snapshot, and try to make a critical fluid decision based on that.
Right. The classic approach.
But here's the rub, and the research is crystal clear on this. A given CVP value,
Right.
it can actually be associated with either fluid responsiveness or unresponsiveness.
That's the crucial point. It's surprisingly unreliable on its own. It's a bit like trying to predict a patient's entire clinical course by looking at just one isolated lab value without any context.
Exactly. No context.
What's truly illuminating is how unreliable those static measures like CVP actually are when you're trying to predict if a patient will respond favorably to a fluid bolus. It often just doesn't give us the full picture.
Yeah.
This is probably best understood through the Frank-Starling curve,
Yeah.
that fundamental physiological principle relating cardiac preload to stroke volume.
Right, the cornerstone.
A patient could have the exact same CEP as someone else, but if their heart is operating in the plateau of their Frank-Starling curve,
Meaning it's already stretched.
exactly, it's stretched to its optimal capacity, well then adding more fluid isn't going to significantly increase their cardiac output.
Yeah.
And here's a surprising fact from the literature. Only about half of ICU patients are actually fluid responsive.
Only half. That's quite striking.
It is. And giving fluids to a patient who isn't responsive, that can actively cause harm, leading to fluid overload and worse outcomes.
So, if those static numbers are giving us such a cloudy picture, what are we really trying to understand here?
Good question.
The core concept seems to be fluid responsiveness, which is clearly defined as the heart's ability to significantly increase its stroke volume or cardiac output in response to a fluid bolus.
That's the definition, yes.
When a patient is fluid responsive, it means their heart is operating on that steep part of the Frank-Starling curve. So an increase in cardiac preload in that sweet spot leads to a significant bump in stroke volume.
Right. You get more bang for your buck, fluid-wise.
But static values alone, as we've just discussed, simply cannot predict this. So if static parameters are leaving us a bit in the dark, what's the cutting-edge approach? What's actually helping us make those critical decisions?
Okay, so this is where dynamic tests emerge as a vastly superior method. Instead of just giving a fluid bolus, which, as we know, can be potentially harmful to non-responders.
Right, you avoid that risk.
Dynamic tests allow us to estimate the slope of that Frank-Starling curve without committing to fluid. It's kind of like doing a quick, non-committal test drive before you buy the car.
I like that analogy. A hemodynamic test drive?
Exactly. And the physiological basis for this is truly ingenious. It harnesses the natural heart-lung conversation that happens during mechanical ventilation.
Heart-lung conversation. I love that phrasing. It perfectly captures that elegant interplay. Okay, could you walk us through the actual mechanics? How does a mechanical breath translate into these crucial changes in stroke volume that we can measure?
Sure. Think of it this way. During mechanical insufflation, that's when the ventilator pushes air into the lungs. It increases the intrathoracic pressure.
Okay, pressure goes up in the chest.
Right, and this increased pressure actually decreases the right ventricular, or RV, preload. It does this by momentarily impeding venous return. You're essentially squeezing the chest cavity slightly, making it a bit harder for blood to flow back to the heart.
Makes sense. And then what happens down the line?
Well, that inspiratory decrease in RV stroke volume then leads to a subsequent decrease in left ventricular, or LV, filling.
Okay.
Now, this isn't instantaneous. There's a slight lag, maybe 2 to 4 heartbeats. That's due to the blood's pulmonary transit time.
The time it takes to get through the lungs.
Exactly. So this LV filling decrease typically manifests during expiration. Now, here's the key bit. If both ventricles are truly preload responsive,
Meaning they're on that steep part of their curves.
yes, if they are, then this cyclic change in LV filling from the mechanical breath will result in significant, measurable cyclic changes in the LV stroke volume.
Ah, I see.
And that's the core principle that these powerful dynamic indices are built upon.
Fascinating. So among these dynamic indices, pulse pressure variation, or PPV, seems to have really become a go-to metric, especially for us anesthesiologists with mechanically ventilated patients. What makes PPV so compelling?
Well, PPV quantifies the variation in arterial pulse pressure during mechanical ventilation, and it's directly proportional to the left ventricular stroke volume variation.
Okay.
What's truly compelling is how accurately PPV predicts fluid responsiveness in these patients. The research shows a really impressive AROC curve of 0.94, using a threshold generally around 12%.
Wow, 0.94. That's not just strong, that's practically a game changer, isn't it?
It really is. It offers near definitive certainty where before we often had to, well, guess or rely on less accurate science.
And how does it compare to stroke volume variation, SVV?
Good point. SVV also reflects respiratory variation in stroke volume, and it's pretty good too, with an AROC around 0.84. But PPV often takes the lead, partly because it's simpler to calculate. It just requires an arterial catheter.
Right, no complex proprietary algorithms necessarily needed.
Exactly. Though, modern monitors do automate this for real-time display, which is incredibly convenient in our fast-paced environments. You see it right there.
Yeah, that real-time feedback is crucial. It's a pragmatic advantage for sure. But beyond PPV, are there other dynamic indices out there that leverage this heart-lung interaction, especially, say, when arterial cannulation isn't an option?
Absolutely. There's a growing suite of non-invasive dynamic tools that can offer predictive power. We're seeing exciting developments with things like respiratory changes in the plethysmographic signal amplitude.
From the pulse oximeter.
Yeah, exactly. And especially with various ultrasound variables. Think about changes in the velocity time integral, the VKI, the LV outflow tract, or aortic blood flow measurements.
Okay, using echo.
Right, or even dynamic measurements of the inferior or superior vena cava diameter and the internal jugular vein diameter. These all really confirm the robust theoretical basis of heart-lung interactions and gives valuable information without needing extra invasive lines.
So we've got these incredibly powerful dynamic parameters, PPV being a prime example, but let's be real. No single tool is perfect for every single clinical situation, right?
Absolutely not. Nothing's a magic bullet.
We need to navigate the nuances and understand their limitations. PPV, for instance, while excellent, has specific clinical situations where its interpretation becomes less reliable, maybe even misleading. And misinterpretation, as you said earlier, can actually be harmful. What are some of those common pitfalls we really need to be aware of?
That's a critical question. For instance, if a patient is spontaneously breathing, even a little bit over the ventilator, or if they have cardiac arrhythmias like atrial fibrillation.
Right, irregular rhythms.
PPV can give you false positives or just be entirely unreliable.
Yeah.
That's because you get irregular intrathoracic pressure changes that aren't neatly tied to the ventilator cycle.
Okay, that makes sense. What else?
Another really common scenario is low tidal volume ventilation, like what we often use in ARDS patients, maybe 6 milliliters or less, or in cases of very low lung compliance.
Right, stiff lungs.
Here, you might see false negatives. The PPV might be low, suggesting the patient isn't fluid responsive, but it's only low because the intrathoracic pressure changes just aren't significant enough to produce a detectable variation in stroke volume.
So the signal is too weak, essentially.
Precisely.
And I've heard that even a high respiratory rate can throw things off. Is that right?
Indeed. A high respiratory rate, specifically when the ratio of heart rate to respiratory rate is less than about 3.6, can also lead to false negatives.
Why is that?
Well, it's thought that the decrease in LV filling might actually happen during insufflation rather than expiration in those cases, which kind of confuses the signal interpretation.
Huh. Interesting timing issue.
Yeah. Plus, you have to consider right ventricular dysfunction. If the RV is failing, You can get false positives, a high PTV, even though the patient is fluid unresponsive because the problem isn't preload.
Ah, so the RV is the bottleneck.
Exactly. And even something like intra-abdominal hypertension, IAH, can affect PBV. It might still predict responsiveness, but the threshold you use might need to be higher. So yeah, it's clear that context is absolutely everything when interpreting these numbers.
Definitely. So, okay, we know the pitfalls. How do we navigate these tricky situations? Are there tests or maneuvers that can help us overcome these limitations when standard PPV might be unreliable?
Yes, thankfully there are. This raises an important question. How do we overcome these limitations? One really elegant solution, especially for those low tidal volume settings we mentioned,
Yeah.
is the tidal volume challenge. It's a simple test. You transiently increase the tidal volume, say from 6 millilograms up to 8 millilograms, just for a minute or so.
Okay, a brief increase.
Right. And if you see an increase in the absolute PPV value of 3.5% or more during this challenge,
Uh-huh.
that can reliably predict fluid responsiveness, even in those low tidal volume settings where the baseline PPV might have been deceptively low.
It's a great example of how a dynamic approach extends to the tests themselves.
Very clever. And what about those spontaneously breathing patients where PPV just isn't really an option at all?
Yeah, that's a common problem. For those patients, the passive leg raising, or PLR, test is incredibly useful.
Yes, PLR. This maneuver essentially creates an autofluid bolus. You're using the patient's own venous blood reserve without actually administering any external fluid.
How does it work again?
You move the patient from a semi-recumbent position, maybe 30-45 degrees head up, to a position where the torso is flat and the legs are elevated, usually to about 45 degrees.
Okay, Trendelenburg-like, but with legs up high.
Exactly.
Yeah.
Then, within just 60 seconds or so, you assess for an increase in cardiac output, maybe using a non-invasive CO monitor of more than 10%, or even a pulse pressure increase of over 15% if you have an art line.
And that rapid change tells you they're responsive?
Yes, that immediate hemodynamic improvement identifies fluid responders without giving a single drop of exogenous fluid. It's very neat.
Right.
There's also the end expiratory occlusion test, the EEO test.
Right, holding the breath at the end of expiration.
Exactly. That leverages similar principles by increasing preload momentarily, useful in specific scenarios when mechanical ventilation allows for it.
And we can't forget the gray zone for PPV, can we? Usually cited somewhere between, 9% and 13%?
That's right, the gray zone. This is where, even under optimal conditions, the conclusion about fluid responsiveness remains a bit uncertain. Is 11% high enough? Is 10% too low? It's ambiguous.
So what can we do there?
Well, here's another neat trick. Transiently increasing tidal volume again, perhaps even more significantly, say from 8 to 12 millilograms if safe, has been proposed to help resolve that uncertainty.
Ah, another dynamic challenge.
It provides that extra hemodynamic stressor needed to push the patient's physiology out of that ambiguous zone, hopefully giving us a clearer answer. Do they respond significantly or not?
That makes sense. Push the system a bit harder to see the response.
Ultimately, these dynamic assessments fit into a broader, more nuanced clinical decision-making algorithm for fluid administration. You don't just give fluids willy-nilly because someone shows a high PPV or responds to PLR.
Right, it's not automatic.
For urgent fluid administration and early shock, think septic shock, active bleeding, the initial bolus, isn't solely based on predicting fluid responsiveness. That's often a critical, immediate intervention you just have to do.
Life-saving resuscitation first.
Exactly. But for continuing fluid infusion, or giving subsequent boluses, you really need to consider three things together. Are there still signs of shock or inadequate perfusion?
Okay.
Have you confirmed fluid responsiveness using one of these dynamic tests?
Right.
And D, critically, are the risks of fluid overload limited? Is the patient showing signs of tolerance?
So need, responsiveness, and safety.
Precisely. And conversely, you discontinue or hold off on fluids when those shock signs disappear, or when the patient becomes clearly fluid unresponsive on testing, or of course if you start seeing signs of pulmonary edema or worsening oxygenation. It's a dynamic, nuanced dance of continuous assessment and reassessment.
That truly highlights how sophisticated fluid management has become, moving way beyond just give fluids. And that's a perfect segue actually into our next point, because the power of dynamic parameters goes beyond just fluid responsiveness, right?
Totally.
It's also about recognizing them as trends over time for predicting adverse events, for seeing trouble coming down the line.
Yes, this is a really exciting area. Think about it. A single snapshot of vital signs like systolic blood pressure, heart rate, or respiratory rate is crucial for early warning scores. Things like new WS or MeWS,
Sure, standard practice on the wards.
and they do predict critical events. But what's fascinating is their accuracy is significantly lower when evaluated much earlier, say 24 to 48 hours before an event, compared to right before it actually happens.
So they tell you something's wrong now, but not necessarily that something bad is going to happen tomorrow.
Exactly. This raises a vital question. Can we get that earlier predictive power? Can we see the subtle changes that herald deterioration much sooner?
And can we?
Well, the compelling evidence points towards respiratory rate, RR, as a key dynamic indicator. The research shows that the change in respiratory rate over time, sometimes called delta RR,
Delta R, okay.
significantly enhances the accuracy of predicting serious adverse events like unexpected cardiac arrest or unplanned ICU admission in hospitalized patients, potentially hours earlier.
How much of a change are we talking about?
An increase in delta RR of, say, 5 breaths per minute or more, especially when combined with a baseline RR that's already a bit elevated, maybe 20 or more, seems to be a major determinant. It's like getting an early warning radar ping, rather than just seeing the storm when it hits.
Wow. So it's not just the static number, the RR of 22, but the fact that it was 16 4 hours ago. That trajectory tells the real story.
Precisely. By incorporating dynamic parameters like delta RR into our baseline static vital signs, we can dramatically improve predictive accuracy, almost getting it to the level of vital signs measured right before the event actually occurs.
That highlights such a powerful synergistic effect. The static value tells you where they are at this moment, but the dynamic trend tells you where they are going.
It's about seeing the movie, not just looking at a single frame.
Love that.
Yeah.
Seeing the movie. And this profound shift in understanding vital signs is, of course, heavily influenced by the rapid evolution of monitoring technology itself.
Oh, absolutely. We're moving towards continuous vital sign monitoring, which is really a revolutionary approach compared to our traditional intermittent checks every few hours.
But getting there isn't simple, is it? The real challenge, I imagine, is implementing and scaling these continuous systems effectively across complex healthcare environments.
You've hit the nail on the head. There are very real-world hurdles. We're talking about, technological limitations, the sheer volume of data potentially leading to alarm fatigue or data overload for clinicians,
Yeah, information overload is real.
the cost of the equipment, integration with our existing, often legacy hospital IT systems, and let's not forget patient comfort and data privacy. Those are absolutely paramount considerations.
Definitely. So how are we tackling those?
Well, what's fascinating here is how non-contact sensors are emerging as a really promising solution to many of these challenges. Imagine devices that monitor vitals without even touching the patient.
No wires, no sticky pads.
Potentially, yes. We're seeing innovative technologies like impulse radio, ultra-wideband radar, microband fiber optic sensors built into beds or chairs, and mat-type air pressure sensors, showing incredible promise.
Wow, radar. How does that work?
It's quite clever. Radar, for instance, can detect the subtle chest wall movements from breathing, and even the tiny displacements caused by heartbeats right through clothing or blankets.
That's amazing. And the others?
Well, some cameras can pick up minute changes in skin pixel intensity related to blood flow changes. With each heartbeat, that's photoplethysmography, but remote. Thermal imaging can continuously monitor temperature or even track blood movement patterns.
So these non-contact sensors sound like potential game changers.
They really could be. They can alleviate skin irritation, which is a common issue with traditional adhesive sensors, especially long-term.
Big plus for patient comfort.
Huge plus. They could also significantly reduce the workload on healthcare providers by automating continuous data collection. Think less time spent manually taking vitals, more time on direct patient care.
And better comfort, as you said, because they're non-invasive and often inconspicuous.
Right. Plus, think about their immense value in infectious disease settings. Reducing direct patient contact is a huge advantage for staff safety and infection control.
True. Are they accurate enough yet?
Their performance is already becoming comparable to traditional methods for many parameters. But, ongoing research is vital. We need to improve accuracy, especially when patients move around a lot, and perfect the signal separation, reliably distinguishing heart rate from respiratory rate signals captured by the same sensor, for example.
Still some refinement needed then.
Definitely. But the potential is enormous.
So what does this all mean for the bigger picture? Where is this heading?
I think this connects directly to exciting future trends like telemedicine and remote patient monitoring, both in hospital and potentially at home.
Right, monitoring patients outside the ICU or even outside the hospital walls.
Exactly. And imagine the incredible potential when you combine these continuous data streams with AI and machine learning algorithms.
Ah, the AI piece.
These technologies can process those vast data streams, sift through the noise, identify subtle patterns the human eye might miss, and distill it all into truly actionable insights for clinicians.
So it frees us up to focus on the decision-making, the art of medicine, rather than just being overwhelmed by raw data.
Precisely. It's about empowering us with deeper, more continuous, and ultimately more intelligent insights into our patient's physiological state and trajectory.
Okay, let's try and bring this all together then. This deep dive has really shown us just how far vital sign monitoring has evolved.
It certainly has.
We've journeyed from relying on those sometimes misleading static snapshots to embracing dynamic parameters that reveal the intricate heart-lung interactions crucial for understanding fluid responsiveness.
A much more physiological approach.
And we've also seen the immense value of monitoring these dynamic trends over time, like delta RR, for actually predicting patient deterioration, hopefully giving us that invaluable heads up much earlier.
Yeah, the shift from simple numbers to understanding the profound story those numbers tell, that's really transformative in how we approach patient care.
It's not just about where a patient is at a single moment in time.
No, it's about where they're going, understanding their physiological trajectory.
And that leaves us, and you listening, with a maybe thought-provoking idea to chew on. In this era of increasing data, continuous monitoring, and rapidly advancing technological capabilities, the real art of medicine in monitoring vital signs isn't just about reading the numbers that appear on the screen anymore.
Oh, it's much more than that.
It's about understanding that dynamic story of physiological change, how it unfolds moment by moment, and thinking about how our understanding of these subtle dynamic shifts will continue to evolve and maybe challenge our current approaches to patient care. How might your perspective on patient monitoring change after today's deep dive? Thanks for joining us.